Okay. Bile salt deficiency is a condition where people cannot produce adequate levels. Their liver cannot produce adequate levels of bile salts. And of course, bile, the purpose of bile is to emulsify fat, to make it easier for your body to, for lipase to then go in and digest fat. So bile doesn't actually digest fat. It simply emulsifies it so that it makes that digestive process easier. So bile salt deficiency can happen in conditions like advanced liver disease, cirrhosis, where the liver, whose responsibility it is to produce the bile salts, or the function is declining. Or sometimes you've got, either with or without advanced liver disease, obstructions of the bile ducts, either within the liver or the common bile ducts. And so there's a problem with the outflow of bile. So the clinical manifestations of bile salt deficiencies, the predominant ones are really related to poor intestinal absorption of fat and fat-insoluble vitamins. So it's not going to be as severe as the difficulty absorbing fat is not going to be as severe as we saw with pancreatic insufficiency, because you are going to be able to digest some fat. So you won't likely see steatorrhea. But because emulsification of fat is designed to actually increase the surface area, okay, of fat that lipase can get to, without emulsifying fat, you end up passing fat-soluble vitamins without being able to absorb them. They get trapped in these large droplets of fat. So the fat-soluble vitamins are vitamin A, D, E, and K, and these deficiencies are associated with other complications. So vitamin A deficiency is associated with a condition called night blindness, where people have a difficulty where they basically stop seeing at night. Vitamin D deficiency decreases calcium absorption and causes things like osteoporosis and bone pain. Vitamin K, obviously important for clotting. Deficiency is going to cause prolonged prothrombin time, bleeding, spontaneous bruising. And vitamin E may cause neurological effects in children if the deficiency occurs in childhood. The other thing that you might see with bile salt deficiency is a clay-colored stool. Stool that is not this sort of classic brown stool, but rather is very pale and clay in color, because it's actually the bile salts that when, bile salts include bilirubin, which get processed by intestinal flora into what's called stercobilinogen, which is actually what colors stool brown. So in the absence of that, it leaves stool very clay-colored. And so when that's apparent, when stool becomes that color, that's a really, really strong sign that there's some sort of bile problem. Okay. Okay. Let's take a few minutes, take a break, and we'll come back and talk about inflammatory bowel disease. So, talking about inflammatory bowel disease. So, inflammatory bowel disease tends to be a term to describe two very similar, especially in terms of manifestations, very similar disorders with very distinct differences: ulcerative colitis and Crohn's disease. Both disorders cause intestinal ulceration. So we're talking now about ulcers in the below the peptic ulcer level, so beyond the duodenum. ulcerative colitis and Crohn's disease are often confused with one another, both clinically and in general, because there are several similarities, but then distinct differences have been highlighted over the years in order to be able to distinguish one disease from the other. So some of the basic differences between ulcerative colitis and Crohn's disease is, number one, the anatomy, what site is involved. Ulcerative colitis, the ulcerations are confined to the colon, to the colon and rectum. It does not involve the small intestine or any other part of the GI tract. However, Crohn's disease, the ulcers can be found really anywhere along the GI tract, including within the mouth, throughout the esophagus, small intestine, stomach, small intestine, large intestine, and anus. The most common area to see ulcers, doesn't mean you won't see ulcers elsewhere with Crohn's disease, but the most common area to see ulcers in Crohn's disease is in what's called the ileocecal region, which is the terminal portion of the small intestine, or the ileum, and the cecum, which is the initial portion of the large intestine. They also differ in terms of the depth of the ulcers and where they start. With ulcerative colitis, the ulcers are sort of a classic ulcer that you think of starting in the mucosal lining and then moving down. Ulcerative colitis can have ulcers that are very deep, but generally speaking, compared to Crohn's disease, on average, those ulcers will not be as deep. Okay. So they are shallow compared to Crohn's disease, where the ulcer in Crohn's disease does not start in the mucosal lining, actually starts underneath the mucosum. It starts in the submucosal lining. And so you get this wearing away of the mucosal lining and a penetrating down at the same time. And so the ulcers tend to be very deep. It can also be quite frequently penetrating. And with Crohn's disease, the ulcers can actually form what we call fistulas, where the ulcer perforates the organ that it starts in, the structure that it starts in, and then perforates an adjacent hollow structure, forming a channel between those structures. And we'll talk more about fistulas later. The pattern of ulceration is very different between UC and Crohn's. With UC, the ulcers are continuous. So if UC starts in, let's say, the rectum, and it starts to involve more and more of the colon, it will be a continuous ulceration. So it moves, and you see ulcers throughout the area that is involved. Okay. As opposed to Crohn's, where the ulcers are more patchy. Okay. They tend to be scattered throughout an area and have a patchiness kind of pattern. And in the large intestine, you can have what's called skip lesions, where, if you can imagine, the large intestine is made up of those haustras, those segments of muscle. The patches skip haustras. Okay? So it's sort of scattered throughout an area rather than being a continuous ulcer. The two diseases also differ in terms of some of the more severe complications and some of the more severe manifestations. And we'll talk more about that as we go along. So with ulcerative colitis, the most common areas for UC to begin is in the rectum or the sigmoid colon. Okay? Rectum or sigmoid colon is the most common area of involvement, especially initially. But as UC progresses, it can involve more and more of the colon. Okay? including more of the descending colon, the transverse, until it can involve the colon all the way up to the cecal area. But it tends to stay confined within the colon. You don't tend to see ulcers progressing into the small intestine with UC. Ulcerative colitis, like Crohn's actually, they are both autoimmune disorders of chronic inflammation. And the mechanism of the autoimmunity often involves autoreactive antibodies against mucosal antigens, autoreactive T cells against mucosal cell antigens, and also inflammatory cytokine attack of healthy tissue. And so an area of colon that's been damaged by progressive ulcerative colitis represents tissue that has undergone chronic severe inflammatory damage leading to obliteration of tissue and fibrosis. Okay. And so here you can see a section of colon that was surgically removed from a patient, and you can see it's fibrotic, it's shrunken, and it's no longer functional. So ulcerative colitis is a chronic reoccurring inflammatory disease. So it causes ulcerations that start in the rectum and the sigmoid colon and tend to involve more and more of the colon. Once the ulcers are established, they don't go away. However, the patient experiences these exacerbations and remissions of symptoms. Okay? So it's not like the ulcers wax and wane. They don't go away and reappear. But the symptoms tend to wax and wane. They tend to, the person experiences exacerbations and remissions. And so in an exacerbation, what people experience depends on how severe or how progressed their disease process has become. So in the mild stages of the disease, during an exacerbation, this person's ulcers, which are confined to the rectum and the rectosigmoid colon, involve intermittent rectal bleeding, some mild diarrhea, mild cramping, and some periods of rebound constipation. Okay, so the passing of bloody stool, loose bloody stool, is actually a hallmark sign of both UC and Crohn's. And in UC, when the disease is at its mild stages, the diarrhea is mild, the bleeding is mild, there's cramping, and then, of course, there's always periods of rebound constipation after the periods of diarrhea. When the person is in a moderate stage of their disease, exacerbations will feel very different. The ulcers are now taking up more of the colon, so it's reached beyond the sigmoid colon, maybe into the descending or transverse. This person's having up to 10 frequent bloody stools a day. Okay, so very, very frequent bloody stools that are very loose. The blood loss may lead to some mild anemia. You may have a low-grade fever from the inflammation. The abdominal pain is certainly worse than it was in the mild disease, but not so severe that not as severe as the later stages. And this person really will be able to maintain their nutrition independently. Their nutrition won't be compromised. And the anemia will likely not require blood transfusions or something to that extent. In the severe disease, you have extensive colonic involvement. It can extend up to the cecum, so you can have total colonic involvement. The loose bloody stools are now greater than 10 per day. You have severe cramps. You have a higher fever, bleeding that often necessitates transfusion, and you may have rapid weight loss that leads to poor nutritional state. So this might be an individual who needs to be hospitalized or at least very closely managed. The onset of both disorders, keep in mind, for UC and Crohn's, the onset of both disorders on average is between age 15 and 30. So you're talking about relatively young people developing this pretty significant debilitating disorder. So the exacerbations and remissions, they come and go. And sometimes these exacerbations can be linked to triggers like certain foods or certain life stressors or other forms of stress besides just psychological stress. But oftentimes the exacerbations are not really linked to a particular trigger. They just follow the sort of basic pattern of this autoimmune flare-up and remission pattern that we see in other diseases. And it progresses that way. With ulcerative colitis, many individuals will require surgical resection at some point, some sort of surgical intervention at some point when enough of the colon is affected. One of the dangerous complications that can occur with ulcerative colitis is a condition called toxic megacolon. And it's essentially an intestinal obstruction. But with toxic megacolon, what you have is the ulceration of a region of colon to the point where the ulcers have penetrated the muscle layers in an area of the colon. Okay. And when the ulcers penetrate the muscle layers in that area of colon, that area of colon dilates. Right? When that muscle is no longer rebounding, it dilates. And when an area of colon dilates, what you essentially end up with is a functional obstruction, okay, where fecal matter accumulates, and it can cause the excess absorption of toxic components. So that tends to be a complication that's specific to ulcerative colitis, that you don't see this with Crohn's, because with Crohn's you don't have the continuous ulcers that allow an entire area of colon to dilate like that. Okay. So Crohn's disease, also an autoimmune disorder involving autoreactive antibodies, autoreactive T cells, and cytokine inflammatory damage to tissue. Right? Also an autoimmune disorder. Also, age of onset is on average between age 15 and 30. It might be even slightly younger, 15 to 25 or something like that. They're fairly similar in terms of their age range. With Crohn's disease, however, the manifestations, while they can include the frequent bloody stool that I mentioned with UC. With Crohn's disease, the manifestations can be much more variable because the location of the ulcer can be anywhere along the GI tract from mouth to anus. Okay? And so it's going to manifest in a much more wide variety of ways compared to UC. The most common place to find ulcers with Crohn's disease, you can have ulcers in lots of places, but you're very likely to see ulcers in at least this ileocecal region. Okay? The terminal portion of the small intestine, where the terminal portion of the small intestine and the initial portion of the large intestine meet. Okay? And as I said, the lesions are patchy, scattered, and not continuous. But the ulcers start more deeply in the wall of the tract and tend to get much more deep compared to the UC ulcers. Clinical manifestations are much more variable. Person can have just sort of general irritable bowel feeling, this sort of upset bowel feeling, lots of nonspecific symptoms depending on the type of where along the GI tract the ulcers are. And then complications can be potentially more severe. Because these ulcers are deeper, the complications can be more severe, including perforating ulcers that expose the contents of the GI tract to the abdominal or pelvic cavity, right? And really risk peritonitis and sepsis potentially. Other complications can involve malabsorption. When you have ulcers affecting the small intestine, now you've got someone who might struggle with maintaining nutritional balance because they can't absorb food. And then some of these ulcers are going to perforate the GI tract and then continue to burrow into a neighboring hollow organ and form a fistula. So fistulas are channels that are formed between adjacent hollow structures. So you can have a fistula that forms between two loops of small intestine. Okay. You can have a channel that forms between two neighboring loops of small intestine. You can have a fistula that forms between the large intestine and the bladder. You can have a fistula that forms between the large intestine and the vagina. Okay. You start to get these channels that allow for GI contents to enter other hollow structures and potentially create very significant complications, including some massive infections. Okay, so this becomes very dangerous, and even more than you see with UC, surgical intervention is almost always required to treat Crohn's disease. But there's a wide variety of, there's a lot of variety in terms of individual expression of the disorder, but with Crohn's disease, it's surgical intervention tends to be required. Okay. Yeah.
With UC, if your whole bone is involved, the GI doctor is just like, let's take the whole thing out.
Mm-hmm.
Essentially, they won't deal with anything after that besides the effects of not having a large bone.
Right.
But they're done after that.
Yeah. Absolutely. And I've known some people who've had that done.
Yeah.
Yeah, who've had I forget what it was called that they referred it to, but that basically most of their large intestine is gone. And there's certainly a lot of management of that, you know, because they're more vulnerable to dehydration and they're more vulnerable to like dumping syndrome and that kind of thing. But yeah, that's the interesting thing with UC is that it's all colonically involved. So if the colon is removed, you're not going to start to see ulcers in the small intestine or anywhere else.
Is it just due to the fact that the all colonic involvement, like the particular kind of mucosa or skin cells that are in the large colon as opposed to the small colon?
Yeah, it's an antigen-specific attack. So if there's some sort of colonic antigen that's being attacked that isn't present anywhere else. Yeah, as opposed to Crohn's, where it's a little bit more, it's a little bit maybe more global. And in fact, people with Crohn's disease have an increased likelihood of like pancreatic problems and liver problems that may not even just be the GI tract itself that gets damaged. Okay, diverticular disease. So diverticular disease is a condition that tends to affect people who, on average, are older. So as you age, the likelihood of diverticular disease increases. And it also tends to be diet-specific. It tends to be a condition of the first world because it tends to be a condition that afflicts people who consume foods that are very low in fiber. So a diet of very refined, very high refined foods, which if you're not in the first world, you don't even have access to those foods very easily. So the reason why age and diet are really the main contributing factors to diverticular disease is because what's going on with diverticular disease is an abnormally high intracolonic pressure. Okay, an abnormally high intracolonic pressure. And when that happens, when you have that extremely high pressure chronically, okay, what you see sometimes is the herniation of colonic mucosa through these little defects in the colon wall. Right? So the colon wall have these little areas where blood vessels penetrate and nerves penetrate, and they create just these microscopic defects in the wall. And if you get enough pressure inside of the large intestine, you can end up herniating the mucosal lining through those defects. So from the inside of the colon, it just looks like a little hole, right? And then from the outside of the colon, it looks like little pouches. Okay? So these little pouches are called diverticuli. The fact that you have the pouches is called diverticulosis or diverticular disease. If one of these pouches were to become inflamed, irritated, if they were to perforate, now that individual has what's called diverticulitis. So the reason why it's age dependent is because colonic motility goes down as you age. Okay? So how strongly your colon can contract goes down as you age, which means that the pressure increases. Right? As the fecal bulk can sort of hang out there for longer and longer times, the pressure gets higher. And if you're consuming food that's very low in fiber, then actually the stools become harder and the bulk is lower. So that further increases the pressure. So simply developing the pouches is usually people have no symptoms. They don't actually, they're not aware that they have the pouches because the pouches themselves don't create any manifestations necessarily. However, the manifestations will certainly come up if the pouches become infected or inflamed or irritated. So diverticulitis, you will get pain, you will get potentially diarrhea, you will not feel, definitely not feel good. And if the diverticuli rupture, then that's a very touchy situation because you've got to be careful of sepsis, right? You're vulnerable to peritonitis at this point. So usually the advice people are given is to prevent this and try to increase your fiber intake as you get older. Control the amount of refined foods that you eat. If you develop diverticulosis, the advice is still to increase your fiber intake so you don't exacerbate it. And then often people are advised to stay away from nuts and seeds, foods that contain nuts and seeds, because the idea is that your body actually doesn't break that down, those things, and that they can get stuck in pouches. And lots of gastroenterologists scoff at that advice and say, I've never seen a nut or a seed stuck in a pouch before. But it's still a sound advice that's given to people with diverticular disease. But I promise you, you'll come across a doctor that says that's silliness. Okay. Okay, so we're going to talk a little bit about liver disease. And what we're going to do actually is talk about many of the clinical manifestations that you see when someone's liver function declines. And then we're going to talk about, actually rather briefly, some of the common causes of liver failure. Okay. So some of the manifestations of liver disease. Liver disease, when the liver fails, the most common scenario is that the liver fails over the course of many, many, many years. We're talking 5, 10, 15 years. And that it's a fairly dramatic and devastating failure because the liver is so essential to the body's function that you see the person deteriorate in many ways. So some major clinical manifestations of liver disease include what we call portal hypertension, which is an elevated blood pressure in the portal vein and the rest of the portal circulation. And the blood that goes into the portal circulation is coming from where? Does anybody remember? From the GI tract, exactly. So you're talking about an elevated blood pressure in that portal circulation of blood that's coming from the GI tract. Another clinical manifestation of liver disease is something called ascites, which is a third space fluid accumulation where you have fluid accumulation in the peritoneal cavity. Okay. Excuse me. There's a condition called hepatic encephalopathy. Hepatic encephalopathy is a set of neurological manifestations of declining liver function. And as we'll talk about later, one of the liver's responsibilities is neutralizing several things that are produced by the GI tract, okay? Namely ammonia, neutralizing that before it enters general circulation. So as liver function goes down, the levels of these toxic substances like ammonia increases and it creates neurological dysfunction. So hepatic encephalopathy. And then jaundice. Jaundice is a hallmark sign of hepatocellular damage, okay, of liver cell death, liver cell damage. And jaundice, of course, is the altered pigmentation of the skin and the whites of the eyes, and the pigmentation is a yellowing or an orange or sometimes even a slight green color. And that pigmentation is coming from an accumulation of bilirubin that we'll talk more about. So many of these manifestations are not only caused by liver disease. Portal hypertension can be caused by other things. Okay? Anything that impedes. So if you think about this, the blood that's going through the portal vein and through the liver is eventually going to drain into what? What'd you say? The IVC, right. It's going to eventually drain into the vena cava and back to the heart. So anything that impedes blood flow through the vena cava is going to create portal hypertension. Okay? However, we're only really going to talk about portal hypertension in the context of liver disease. Okay? And in that context, the impedance of blood flow is actually because of the liver itself. The liver is diseased, it's shriveled, it's fibrotic, and the flow of blood through it is impeded. Okay? Ascites, we know, is caused by more than just liver disease. Okay? Ascites can be caused by a variety of things. However, we're only concerned with the ascites we're only going to really focus on the ascites that's secondary to liver failure. Hepatic encephalopathy, jaundice, same thing. So portal hypertension, abnormally high blood pressure in the portal circulation. Portal circulation, the blood pressure is normally extremely low. So if the normal pressure in the portal circulation is like 3 millimeters of mercury, portal hypertension, we're only talking about potentially 6, 7 millimeters of mercury. So it's not empirically high, but you're talking about a doubling, right, or a tripling of the pressure. So we're still talking about fairly low pressures, but it's still abnormally high for what it normally is. Excuse me. And the elevation in that blood pressure, as I said, is going to be caused, for our purposes in this discussion, it's going to be caused by the change in the liver structure that causes an impedance of blood through the liver. Okay. Now, this portal hypertension that goes along with chronic diseases of the liver, the portal hypertension actually leads to another entire set of problems. Okay? So persistent portal hypertension in the long term is going to cause what we call varices, which are these tortuous varicose veins that we find in the lower esophagus and the upper stomach. Okay? And we'll talk about the real emergency is when these varices hemorrhage or bleed. Ascites, okay? The ascites that we talked about up there, portal hypertension plays an important part in contributing to the development of ascites. Enlargement of the spleen and hepatic encephalopathy, right? So portal hypertension is a root cause of a large variety of liver disease manifestations. So to get an orientation of portal circulation and how it relates to other circulatory routes. So what we're looking at here is a view where a portion of the liver has been cut away so we can actually see the veins beneath it. And also the majority of the small intestine and large intestine has been moved away so you can't see it. Okay? So if you see this vessel, these vessels are leading to the GI tract, the small intestine, and the large intestine. And the one thing that they're showing you is the veins of the rectum, okay? That these veins of the rectum that are draining into these larger veins that eventually drain into the portal vein. Okay, so the direction of blood flow is small and large intestine. Blood drains into the superior mesenteric vein, inferior mesenteric vein, into the portal vein, and then into the liver. Okay, and then through the liver and onto the vena cava. Make sense? Also draining into portal circulation is the splenic vein. Okay. Also draining into portal circulation is the splenic vein, and also there are veins, gastric veins of the stomach, and esophageal veins of the esophagus. These are all tiny little veins that are all eventually draining into larger veins that drain into portal circulation. When the pressure in the portal circulation doubles or triples, okay, what that creates is increased pressure in all of these branches. Okay? It's going to interfere with the ability of that blood to drain into the liver. So what that means is, one of the things on that list was enlargement of the spleen. Okay? So when blood is not readily draining out of the spleen gets huge, to the point where it's very easily palpatable for people with liver failure, cirrhosis. What also happens is the development of these varices, these varicose veins. And the sites where you see these varicose veins, or the varices, are the lower esophagus, the upper stomach. Okay? And we know varicose veins are when the valves in the veins prolapse, right? And they just fill with blood and they just get tortuous. And they may have originally started off as a tiny little vein, but now it's just this big, fat, unstable vein. Another set of varicose veins are in the rectum, right? So people with portal hypertension can get these hemorrhoids. That's what we call the varicose veins in the rectum. Now, let's talk a little bit about these varices that are forming, these varicose veins, and specifically in the esophagus and the upper stomach. The real danger with these varices is if they were to rupture. So the rupture of the varices in either the upper stomach or the lower esophagus can cause a massive bleed. It can end up causing the vomiting of large volumes of blood and a significant loss of total blood volume. Okay. The mortality rate on something like this happening is above 50%. It's a very, very dangerous situation. Okay. So you're talking about now, this is a really abrupt hemorrhage where the varices break open and then you get this vomiting of huge volumes of blood. Another, which can lead to hemorrhagic shock. Another possibility is more of a slower bleed. Okay? Not such a massive rupture, but rather these varices start to bleed and they bleed into the stool. Okay? Or they bleed into the GI tract. And when that happens, you will see this sort of black, tarry stool because of the presence of blood. It can lead to anemia, but it can also lead to acute complications because the person who has these varices has liver failure, right? Their liver's not really functioning anymore. And the blood that is bleeding into their GI tract is going into their stomach, into their small intestine, and it's very high in protein, right? It's blood. And so their body's actually being forced to digest it. And without a liver to detoxify the protein, the high amounts of protein they're consuming, they get into wild hepatic encephalopathy, right? And we'll talk about the makeup of that later. But what you're talking about potentially this low-level bleed turning into a very, very serious event, potentially leading to coma and death. Okay. And I'll talk more about hepatic encephalopathy, but basically being forced to digest your own blood can acutely raise your ammonia levels and lead to that neurological manifestation. So varices it's directly caused by portal hypertension, right? Development of varices directly caused by portal hypertension. And the real danger is bleeding, whether it's hemorrhagic bleeding or this low-level bleeding into the stool. Portal hypertension contributes to ascites. The word ascites comes from the Greek word askos, which means bag or sac. And it really describes a pathological fluid accumulation in the abdominal and peritoneal cavity. Ascites traps fluid in this third space, and it cannot escape. It's really a chronic problem. There are a couple of key things that cause ascites, key problems in this patient that's causing ascites. The two major ones are portal hypertension and a lack of albumin. Those are two major causes of ascites. So let's start with albumin. Albumin produced by what organ? The liver, right? The liver synthesizes albumin. People become hypoalbunemic when they are in starvation states because they don't have enough protein to produce the albumin, or when the liver fails and they can't produce the albumin. So the liver stops producing albumin. Albumin determines plasma oncotic pressure. So when albumin drops, plasma oncotic pressure drops. Plasma oncotic pressure was the pulling pressure keeping fluid in your bloodstream. So when that diminishes, fluid is constantly escaping, right? So person doesn't have enough albumin, and now you start to see excuse me, you start to see lots of pitting edema all over the place, right? So they're generally going to be really puffy. But it's also going to promote the movement of fluid into that cavity. Okay, it's going to promote that development of ascites, okay, the lack of albumin. That's one thing. The other thing is, remember, this person has portal hypertension. So some of the vessels whose pressure has increased are the mesenteric vessels that are facing the abdominal and pelvic cavity. So that increased pressure is going to increase the pushing pressure, right? The capillary blood pressure pushing fluid into that third space. Okay. So portal hypertension is going to contribute to the increased capillary blood pressure pushing fluid out into that cavity. Okay. So lack of albumin and a drop in plasma oncotic pressure increased capillary blood pressure with portal hypertension. And then there's another factor which sort of ties in all of it. This person with chronic liver disease, their circulatory system is constantly trying to recover blood volume, okay? Because every time they get, all of their blood volume keeps leaking out of the blood vessel because they don't have enough albumin. Make sense? So that means that their blood pressure actually is low because they can't maintain their blood volume. And when your blood pressure is low, that activates your renin-angiotensin system. So you start conserving water and sodium, and you actually are trying to retain fluids so you can recover your plasma volume. But it's a completely useless effort, okay? Because all the volume you're retaining is going to escape out of your blood vessels. And it's going to contribute to your peripheral edema. It's going to contribute to your ascites. Okay? So you have this really paradoxical situation where this person looks like they are just totally fluid congested, but in fact their blood volume is depleted because they don't have the albumin to keep it in the blood vessels. Okay? And the liver does break down antidiuretic hormone and aldosterone. And so with declining liver function, it extends the half-life of those hormones. So they're even more effective. They're going to tend to contribute to even more water and sodium retention. Go ahead. Yeah.
When physicians want to transfuse them albumin to help with this high pressure, why do they say it only lasts for a short period of time and they don't really want to infuse it that much?
Well, putting albumin into somebody is the albumin, it's going to have a half-life. It's going to be like a drug, you know. The protein gets in your body, and just like any other protein in your body, goes through your liver and your kidneys, and it gets removed eventually, right? So it's going to get metabolized and excreted just like any other drug. So if you don't have a constant endogenous production of it, right, it's going to move through you and get removed eventually. But constantly giving somebody fresh albumin all the time, it increases the likelihood that they're going to develop an immune response to that albumin, right? Because it's not something their body is producing. It's the same thing with heparin. You know, you take heparin a lot, and then all of a sudden you get an immune response to heparin. So you want to balance, you know, correcting an acute problem, you know, giving them the albumin to correct the acute problem, but knowing that it's not going to last very long, you don't want to continuously give it and create a sensitization and an immune response. Does that make sense? And, yeah, and it's expensive. So once ascites develops in a patient, paracentesis is really the only way to remove that fluid, and that's literally the physical removal of the fluid. And that actually can be kind of dicey because during the removal of the fluid, this individual can become very hemodynamically unstable. If you can imagine this, and I've got actually a picture of somebody with some pretty severe ascites. If you can imagine this person is actually a very slender man, right? All of this abdominal girth is fluid. Okay? And anybody know when I learned this, I thought that was very neat, what the physical exam technique of deciding whether it's the fluid wave, right? Is it fat or is it fluid? and it's the, tapping the belly on one hand and feeling the wave on the other side. Fat doesn't do this, right? Like this belly doesn't wave, but that belly does. So if you imagine this individual has got a significant amount of fluid, multiple liters of fluid in his peritoneal cavity. And that's creating a very strong hydrostatic pressure against his mesenteric capillaries, right? What starts to happen when you start to pull that fluid? What happens to that hydrostatic pressure? It starts to drop, right? And so you're changing the balance of pressures. And as that hydrostatic pressure starts to drop, you can actually end up getting a significant fluid shifting, right? A rapid fluid shifting. And when that happens, that person's blood pressure could crash very quickly. So the removal of fluid has to be very slow and careful, and also the person has to be carefully watched in terms of their blood pressure and their hemodynamics. Exactly.
Hydrostatic pressure is kind of making up for the low volume, and you take away what's compensating for that, and then they just have no volume left.
And that's a great descriptor. They're cardiovascularly dry, right? Because they're so fluid engorged, but in their blood vessels they're dry. Exactly. But that hydrostatic pressure in their interstitial space is actually keeping the fluid in their blood vessels. So removing it actually can make them even more dry. Okay. So hepatic encephalopathy, another one of these manifestations of liver disease. Excuse me. I've been praying my voice lasts. So hepatic encephalopathy, it's a neurological syndrome, and it's characterized by impaired cerebral function. You get things like flapping tremors. There's actually a word for the tremor I'm trying to... What is it? Asterixis, that's right. Yeah, it's a hand tremor that happens with, it's a manifestation of hepatic encephalopathy. But they get personality changes, cognitive changes, memory, attention, mood. They become very emotionally labile. It's a really dramatic neurological syndrome, and it even creates very observable changes on an EEG. Okay, so you're talking about very changed brain function. And the other part of hepatic encephalopathy is the neurotoxins that are actually causing the manifestations are also temporarily increasing the blood-brain barrier. Excuse me, they're increasing the permeability of the blood-brain barrier. So this person's brain is actually more vulnerable to exposure to toxins. Okay. So it can develop rapidly or slowly with chronic liver disease. It can also, you can also have episodic events of acute exacerbations of encephalopathy. So people with really end-stage liver failure have a low-level constant encephalopathy going on. So they're really not themselves. But they can have specific events that create worsening of that encephalopathy. So the idea behind what's causing this syndrome, what causes hepatic encephalopathy is the diversion of blood away from the liver, or the lack of liver detoxification of blood. Okay. So either the blood is getting diverted away from the liver for one reason or another, or whatever blood that's going through the liver is not getting appropriately detoxified. So in the process of digestion, the GI tract produces a whole host of substances that are toxic to the body, but that are neutralized, bless you, by the liver. One of those substances is ammonia. There are others, but ammonia is really thought to be a major player in hepatic encephalopathy. Another substance that's thought to play a role is GABA, GABA-aminobutyric acid. And GABA is a neurotransmitter. It's an inhibitory neurotransmitter. And there's lots of GABA released by neurons in the enteric nervous system. And any spillover of GABA into the blood gets sopped up by the liver. The liver removes it normally. In a patient with a failing liver, the ammonia is not getting neutralized, the GABA is not getting metabolized, and it's entering general circulation, and it's affecting the brain. It's making the blood-brain barrier more permeable, and it's altering brain function. Okay? And that is really the heart of encephalopathy. So the sorts of things that are going to make ammonia levels higher, or GABA levels higher, or encephalopathy more acutely severe is going to be large protein loads, right? Consuming large protein loads, including that bleeding of the varices into the stomach that we talked about earlier. Any kind of intestinal obstruction. So the more slowly feces moves through the colon, the more ammonia that's produced by the bacteria in your colon. Okay? So you can have a patient who has end-stage liver disease, and something minor like they get constipated causes their ammonia levels shoot up, and they go into this very, very acute encephalopathic problem. Their encephalopathy becomes very, very severe. Okay? And so patients who are suffering from end-stage liver disease tend to actually be taking that lactulose stuff all the time. It's not a diuretic, it's a laxative, thank you. It's a laxative that just helps prevent any kind of intestinal obstruction or constipation in order to minimize the ammonia that gets absorbed. So hepatic encephalopathy is graded from 0 to 4. So when I'm talking about an acute encephalopathic episode, I'm talking about going from 0 to 1 or 2, where these end-stage liver disease patients really live all the time, going all the way to 3 or 4, right, in an acute period of time, and then coming back. Yes, ma'am?
Is the ammonia a byproduct of protein?
Yeah. Your body breaks down protein and it produces ammonia, and then intestinal colonic bacteria produce a lot of ammonia. And usually that enters the blood, it goes to the liver, and it gets neutralized. So a grade 0, this is someone who probably only his or her family notices the difference, right? Clinically normal mental status, but minimal changes in memory, concentration, intellectual function, coordination, just sort of like these really subtle differences. Grade 1 becomes much more observable. Mild confusion, very emotionally labile, so euphoria, depression, decreased attention, a slowing of their ability to perform mental tasks, irritable, altered sleep, and sometimes that manifests as like an inverted sleep cycle, where they tend to have insomnia at night and want to sleep all day. Grade 2 going from grade 2 to 3, now you're getting into potentially a serious episode. Drowsiness, lethargy, gross deficits in their ability to perform tasks. Okay? They're really, really not there. Obvious personality changes, inappropriate behavior, disorientation, and the disorientation can be with respect to a lot of things, but especially with respect to time and place. Grade 3, they seem to not be awake, but they can be aroused. They're not performing any mental tasks. They are disoriented in multiple ways. They have marked confusion. Fits of rage might happen, incomprehensible speech. And then 4 is coma with or without response to painful stimuli. Okay, so really, it can really become quite severe. And it's a really hard thing to go through. And usually those people, what's that?
They always poop in the corner.
And they poop in the corner?
We used to have a bunch of these, and every single one of them would, you'd walk in and they'd be squatting in the corner pooping.
Yeah.
You'd just be like, why?
Well, I mean,
All the packets of love that you can make from the station.
well, if you had to poop, you didn't know where you were. A corner's not a bad choice, right? I mean, that's, I think most animals choose a corner. Right.
It's always a corner.
Yeah. Better divide your corners up early if it's going to, yeah.
Stay away from that corner, man.
Mm.
I don't want to go there.
So, yeah. Jaundice. Jaundice is another very, very common, it's actually a hallmark sign of hepatocellular death or damage. And with jaundice, the essential problem with jaundice is that you have elevated circulating bilirubin in your blood. And bilirubin is a substance that, in its natural form, bilirubin is very, very lipid soluble. And so it can very easily deposit itself into tissues like the skin and create that discoloration that we're talking about. Okay? The yellowing or that sort of yellow or orangey color to the skin, or the whites of the eyes, or the soles of the hands and feet, wherever is most noticeable depending on the person. So if the problem is bilirubin, let's talk just a little bit about where bilirubin comes from and how the body processes bilirubin. So bilirubin actually comes from the breakdown of red blood cells by the spleen. So red blood cells go to the spleen, and the ones that are sort of aging and not the optimal shape to get out of the spleen get trapped in the spleen. And the spleen starts to disassemble them. And all of the protein basically gets recycled. And then the hemoglobin gets taken out of the red blood cell. The protein gets reused, the iron gets reused, but the heme group that the iron was attached to, that heme group actually does not get reused. It gets converted into bilirubin. Okay? So it comes from the heme group on the hemoglobin in red blood cells. So the bilirubin leaves the spleen in its natural form. And that form, we call that unconjugated bilirubin. Because that bilirubin, unconjugated, is very fat soluble. Okay? And the next place it's going to go to is to the liver to become conjugated. And when we conjugate bilirubin, what we're doing is actually attaching a sugar molecule to this bilirubin structure. Okay. Now the reason why we conjugate it is because lipid-soluble substances, we don't have good control over the movement of those substances because they diffuse across plasma membranes. But if you attach that sugar molecule, right, which is water soluble, now we can keep track of this bilirubin and we can make sure it goes where we want it to go. Now the unconjugated bilirubin, when it traveled from the spleen to the liver, okay, it traveled out of the splenic vein into the portal vein and into the liver. And it had to be bound to albumin in order to get there, right, because it's a lipid-soluble substance. So now conjugated bilirubin, the kind of bilirubin we like because we can keep tabs on it, leaves the liver through bile. And it gets stored in the gallbladder with bile, and it gets released into the duodenum with bile. Some of the bilirubin, conjugated bilirubin in the GI tract gets converted into that stuff that makes feces brown. Some of the conjugated bilirubin actually gets unconjugated and gets reabsorbed. The rest just gets excreted, okay? So with liver disease, the reason why you end up with a buildup of this natural bilirubin that deposits into your skin, there's many sources of the problem. Number one, when you're talking about acute liver damage, okay, before you get to the point where somebody's in end-stage liver disease, just acute liver damage, okay, all of a sudden the person gets jaundice, and then they can recover from it. What's happening is there's something killing off or disabling or harming these liver cells, and the liver is not conjugating bilirubin. And so you get this rise in circulating unconjugated bilirubin. And that causes the jaundice. Yeah, exactly. It can get out of the blood vessels, it can get into the skin, it can get into, yeah. So the acute liver damage that causes jaundice, that's happening because the liver cells are getting attacked, they're dying, and they're not conjugating bilirubin. So the person turns yellow or orange, they got bilirubin in their urine, their blood bilirubin levels are high, they got all of it. But when the acute damage to the liver subsides, everything goes back to normal. The liver recovers, it's an amazing organ. It starts conjugating bilirubin again. When you talk about a patient with end-stage liver disease, they can seem to be somewhat yellow or orange all the time because, number one, there's a limited amount of this conjugation going on of bilirubin. Okay? Number two, they've got portal hypertension. So there's an impedance of blood flowing from the spleen into the portal vein, into the liver. Okay. Number three, they have less albumin. So bilirubin it's even easier for bilirubin to get out of the blood vessel because there's less albumin to keep it in there. Number four, thank you. Movement of feces through the colon tends to be slow because of this sort of dehydration that people have, this paradoxical dehydration. And that tends to increase the rate at which the flora in the gut unconjugates bilirubin. 4 was the slowing of gut motility. Promotes the unconjugation of bilirubin in the colon. Number 1 was less conjugation by the liver. Number 2 was impedance of blood flow out of the spleen and through the portal vein, right, the portal hypertension. Number 3 was the lack of albumin. That means that bilirubin can't be kept into the blood vessels. And number 4 is reduced gut motility enhances the unconjugation of bilirubin. Okay. So a lot of different reasons why acute or chronic liver conditions can lead to jaundice. Okay, so those are the major manifestations. Let's talk a little bit about what causes major liver dysfunctions or major liver disease. The word hepatitis actually refers to inflammation of the liver. That's the definition of hepatitis. And there are many causes of inflammation of the liver. Viral hepatitis is one cause. So there are certain viruses that tend to infect and attack hepatocytes. They tend to like to infect liver cells. And as a result, they cause chronic inflammation and progressive, in certain cases, progressive fibrosis of the liver. So there are 5 known strains of the hepatitis virus. Some of these strains of the hepatitis virus cause acute disease, meaning you get acutely sick and then you recover and you never have problems again with it. And some of these strains of the virus cause chronic disease and potentially chronic liver damage. They all have different modes of transmission and slightly different life cycles. But what they all have in common is that their preferred cell to infect is the liver. So the Hep A virus is a virus that causes acute illness. The mode of transmission is predominantly a fecal-oral route. So you shed virus in your feces, and then usually through some sort of food contamination, people spread the disease. Okay. For all of these forms of the virus, there's usually an incubation period. There's a period where between the time where you're exposed and where you first start to manifest signs and symptoms. And that incubation phase varies, but it can be anywhere between 2 to 6 weeks. Okay. So Hep A, acute disease caused usually by fecal-oral transmission. Hep B causes chronic disease. And Hep B is transmitted through a parenteral route. So it's usually non-contaminated blood, to a certain extent, sexual transmission. Hepatitis D is a virus that you can only become infected with if you already are infected with hepatitis B. So hepatitis D, you can only get if you already have B. Yeah. And hepatitis D, getting hepatitis D when you already have B is sometimes a cause of what's called fulminant hepatitis, which is basically acute liver failure. I'll write that word down, fulminant hepatitis. Man, I can't even think. So hepatitis D has a similar transmission as B. So you have to already have B in order to get D. And oftentimes people who get the D strain go into this form of acute liver failure called fulminant hepatitis. They don't have to, but sometimes they do. Hepatitis C, also caused by also causes chronic disease, and it is also parenteral transmission, usually due to exposure to contaminated blood. And hepatitis C is a pretty aggressive virus that will usually eventually lead to end-stage liver failure, will usually lead to cirrhosis. Hepatitis B can also eventually lead to cirrhosis and liver failure, but there are some patients that don't seem to progress who have Hep B, especially those that contracted the virus very early on in life. They don't tend to progress to B, they don't necessarily progress to failure, but Hep C is a much more direct line to failure. And then hepatitis E is actually clinically identical to hepatitis A. So it's causes acute disease, fecal oral route. The E virus was only recently discovered, and because it was always assumed to be A because it clinically behaves identically, but it has been found to be a separate strain. It's just the genetic makeup of the two viruses, but they behave, identically. So if we look at these sample biopsies of liver tissue, we've got a normal biopsy on the top. We've got mild to moderate hepatitis. If you notice, with the normal biopsy, we have these nice sort of rust, pinkish colored liver cells. You've got these things called portal triads. And these portal triads are actually a branch of the portal vein, a branch of the portal artery, and branches of the bile ducts. Okay? And so it's within these portal triads that blood comes into the liver and bile flows out. So you can see with mild hepatitis and moderate hepatitis, the inflammation tends to be centered around these triads, because it is the point through which the blood enters the liver. And so the inflammation and also the expanding fibrosis, right? As this inflammation is goes chronic, especially in terms of Hep B and Hep C, the bands of fibrosis also originate at those triads. Okay. forms of viral hepatitis, there's an incubation period followed by what we call a prodromal period. This is a period of time where you start to see the onset of more nonspecific symptoms. Symptoms such as fatigue, nausea, headache, fever, okay? Very nonspecific symptoms. And then after the prodromal phase, all forms of viral hepatitis will then progress into what's called the icteric or the jaundice phase. This is thought to be the acute phase of the illness. It comes with the onset of jaundice. After the acute phase, after this jaundice phase, the acute forms of viral hepatitis progress into a recovery phase, and the chronic forms progress into a chronic phase. And with chronic hepatitis, the severity of the symptoms go down dramatically. However, the virus continues to cause progressive hepatocellular death and damage, and inflammation and fibrosis. So with the chronic diseases, your immune system was not able to completely clear the virus, and the virus persists. But it persists at a much more slow rate, and you're not acutely ill. Okay. So viral hepatitis, especially Hep C, can lead to a form of cirrhosis that we call post-necrotic cirrhosis. Post-necrotic cirrhosis simply means cirrhosis that has been secondary to progressive liver necrosis, okay, progressive liver damage and death. Another cause of cirrhosis, a very common cause of cirrhosis, is alcoholic cirrhosis, which is caused by alcoholic hepatitis. And that's due to chronic hepatocellular damage caused by alcohol abuse. We talked in the beginning of the semester about how alcohol is metabolized by the liver. It produces acetaldehyde, which is hepatotoxic. Right? And so it's the acetaldehyde that causes the persistent damage to the liver. Those are two of the most common and the most important causes to understand in terms of leading to cirrhosis. Once someone has cirrhosis, their liver looks something like this. What's very typical of cirrhosis are these very, very thick bands of fibrotic tissue that separate these nodules of regenerated liver tissue. So the liver is trying very hard to regenerate itself, but it is choked by all of this fibrotic tissue. And if you notice, those triads are right here, right at the center of the fibrotic bands. And it's those triads that have the branches of the portal vein. And that's exactly that choking of those triads is exactly what causes that portal hypertension, the impedance of blood flow through the liver. Right? So the liver goes from being this soft and supple, healthy organ to this sort of shriveled, very much harder in texture, fibrotic organ. And once you hit this stage, the cirrhotic stage, there is just no, this is completely non-reversible, right? And so the only curative treatment is transplantation at this point. Unfortunately, once you get to, excuse me, once you get to this point, it's not uncommon to see development of cancer, carcinoma within the liver tissue, and that carcinoma is going to be secondary to this chronic inflammation, this chronic damage that's occurred. And the discovery of patches of carcinoma within a person's liver can change their standing on the transplant list dramatically. Right? So it doesn't always completely disqualify them, but it becomes harder. And so here's two very different looking cirrhotic livers, but you can see that the bands of fibrotic tissue and the nodules, whether they're small nodules or large nodules, are really clear. Okay. Questions?
They have hepatitis, like you said, you said viral hepatitis only attacks the hepatic cells,
Right, right.
but it's in the bloodstream.
Yeah.
So people with hepatitis are not transplant recipients, right? Because they're going to get it anyway.
They are.
The bloodstream.
No, they are. People with hepatitis do often get transplants, and the protocol's changed over the years, but it really depends on the person's total picture in terms of their potential lifespan afterwards. Nowadays, what they'll actually do is try to treat people. If you have to leave, please feel free to go. What they try to do is treat people with like interferon therapy to try to get the viral load down, and then offer them the transplant. But the reason why it's not such a kiss of death, with having like Hep C, for example, is that post-transplant, you're so immune suppressed that whatever virus is there is not going to be aggressive, because you don't get this, your immune system isn't constantly fighting it, damaging the liver.